to the test. To start a little bit on clinical. So basically, I'm going to go over that part. So we went over depth doses. We went over what TAR is and what it does to the energy. We did some weighting. Who wasn't here last week? Okay. So basically, if you go over chapter 22, a look the first part of it, don't go into all the stuff at the back. Just the first part. TAR, TMR, percentage depth dose, that type of thing. Okay. Maynard factor, I've sent you something on that, but all you need to know is when we use it. So can you remind me when you use the Maynard factor? Maynard factor.
When using extended SSD.
Only when you use extended SSD. You need the Maynard factor. Okay, so let's go over some weighting. So we have, for those of you who aren't here, I have two parallel opposed fields, and they're equally weighted 6 MV fields, photon fields. The separation is 20 centimeters, and they're treated with an SSE technique. Where does a maximum dose occur? So let's see. Okay. So you have a treatment field, patient. 100 SSD. Separation is 20 centimeters. So the patient's 20 centimeters thick, little skinny person, 20 centimeters thick. Where does the 100% of the dose occur? Anybody tell me?
1.5 cm depth.
Okay, why?
Dmax for 6 MV.
Dmax for 6 MV. Everybody agree with that? Everybody know why? Everybody figured it out? Okay. So if it was a 10 MV, so this is a 6x. If it was a 10x, would the, here's Dmax. For 6x, it's 1.5 centimeters. Would 10x be further this way, or further this, or closer to the skin? Deeper. So it would be here somewhere, right? And where does here?
2.2.
2?
2.2.
2.2?
For 10 MV total.
Okay. Always remember centimeters. Okay? Somebody's gonna pull you up. Okay, so that's good. Okay, so anything that's placed in the way of the field has to be corrected when you're doing a calculation. True or false?
Say again?
Wakey, wakey. Somebody give me some coffee. If you have something in the way of the field, so your field is coming down here and you put something in the way of the field. Do you have to compensate for that?
Yeah.
And what do you do for that? Does that make, so remember what MU is? Okay, what's MU? Monetary units, yeah. So if there's nothing in the field and we are giving 200 centigrade and the MU just happens to be 200 MU because we have a 10 by 10 field, which is 1 centigrade per MU. If I put something in the way of the field, does it make the MU greater or less? Do you have to give more MU? Sorry. It depends on how you ask it, right? She's right in a way. Yeah, she's right one way. Do you have to give more MU to get the same amount of centigrade or not? Yeah, so you have to give more MU to give the same dose. Okay, here's one that's actually on the test. The MU setting is calculated for opposed treatment fields with a 45-degree wedge, or 45-degree wedges actually. The therapist does not use the wedges and uses the wedged treatment MU setting. The error could result in a severe overdose or death of this patient. True or false?
Could you repeat that one more time?
Sure. I'll repeat it first. So the MU setting is calculated for opposed treatment fields with 45-degree wedges. The therapist does not use the wedges, and however, she uses the wedged field MU setting. The error could result in severe overdose or death of this patient. And Molly's just said true. Does anyone disagree with that? No, it's true. Because you're putting wedges in, therefore you have to up the MUs to get the same dose. Because the 45, especially the 45-degree wedge, absorbs a lot of the MUs, or a lot of the dose. Therefore, you have to give more. Therefore, if you leave the wedges out, the patient is very much overdosed. So in the same way, is the midline dose of that patient decreased, and is the isodose distribution changed?
In the same exact scenario?
Yeah.
So the isodose would be changed. And what was the first part of the question?
The central axis dose. You've already answered that one, yeah. Yeah, the dose changes because you're giving more than you should do, because the dose is calculated for the wedges. You've left the wedge out, therefore the dose is changed. And the isodoses are done, or the plan is done with the wedge in place. You take the wedge out, your isodoses completely changed. So you may be treating the wrong area to the wrong dose. Okay. Okay, here is one that we did, which is relatively easy. Okay. Patient depth from the AP at SAD 100. The SSD to the skin is 90. What's the depth? Jimmy? 10 cm. Everybody agree with that? Yeah. Okay. So from the PA, same scenario, but the SSD is 87.5. What's the depth?
$12.5.
12.5. Everybody agree with that?
Me and subtraction, dude. It's like my brain can't do it. Like, I
13, but.
got
The point,
I
there's
said
a point 5.
12.5.
Oh. I was wondering where the
Yeah.
point came from.
Oh, sorry, it was 87.5.
I only got wrote 87.
So it is, everybody agree with that, it's 12.5?
calculator for that.
Yeah. So, okay, so we have the AP and the PA depths. What's the separation?
What was the AP one? Forgot.
Pardon?
What was the
22 point.
10,
12, yeah, 22.
22.5. And please don't tell me you need it.
No.
Okay. It's just the,
I just couldn't remember what you said.
Yeah.
Sometimes just subtraction with funky points and stuff. Yeah, no, that's just not for me.
You're gonna have to get over that, because you
I know,
cannot
I
take a
know.
calculator into the room with you every
I
time.
know, and I can do it when I can think about it, but when I'm under pressure, it's like, what is this? And I'm like,
Okay. Okay, so let's go to the transmission factors. So you have several transmission factors. Transmission factors are called into use when you put something into the beam. So transmission factor for a tray, not the blocks, just the tray. So this would be the tray. Where's my cerament? Here we are. So this is the kind of tray we're using, okay? This is Perspex. So that's the tray we're using. And that's a tray that you can use that one, or you can use a solid one. This one has little holes in, but you can use a solid one. So the tray factor is something that is usually given to you.
Does the tray factor change with the holes?
It can do, but most departments use the same type of tray. So usually the tray factor is common to everybody. But they'll give you a tray factor. If you have a calculation that includes a tray, they'll give you the tray factor. However, a tray holding custom blocks is measured at 97 centigrade. The dose without the tray is 100 centigrade. What's the tray transmission factor?
97%.
No, well, that's not the tray factor. 0.97. Yeah. The tray factor is always less than 0. So it's 0.9 or less than 1, I should say. So it's 0.97, and it has been for the last 40 years. It's always 0.97. unless you have some kind of weird trace that you're using. But then they will give you the trait factor. So if you have to get a patient and give them 200 centigrade, you have to take into account the trait factor as well as all the rest of the factors that you have to use. Okay, equivalent square. We did this just last time. Equivalent square. Here's where you get your calculators out, ladies and gentlemen. The one that I'm going to give you is the one in the, because I don't have a calculator. So anyway, 20 by 10. What's the equivalent square for 20 by 10? And those of you who were here last time, should know it. But please don't shout it out until everybody has finished looking at it and calculating it. Everybody got an answer? Okay, somebody give me an answer. 13.3333333. Ready with that? Which way did you do it, guys?
I just remember that E equals 4 times A over B.
Everybody do it the same way? Okay. That's included in that little thing that I sent you this morning. The 2 ways to do it. Okay, so, is there another name for D-max? I'll give you 4
No.
Maximum equilibrium.
maximum equilibrium. Yeah. Okay, so I did this, I'm going to do this one differently. So this is the weighting. So you have okay, so you have an APPA field. APPA. And the physician wants the APPA field to be weighted 4:1 PA. Oops, PA. And the dose he wants to give is 250 centigrade. The total dose for the day is 250. So, what are your doses and how did you get it?
50 on the 50 on the AP, right? Because it's 4:1,
Right?
and 200 on the PA. It's 4 times the.
Okay. So how did you do it?
I added 4 and 1 together to get 5, and then I divided the total dose by the 5.
So 250 divided by 5 is 50. So It's 4:1 to the PA. So the 1 is the AP, which is 50, times 4 is 200. Easy peasy. It doesn't work like that in real life, but that gives you the idea. Okay. Okay. Can somebody tell me the definition of absorbed dose? Or your idea of what absorbed dose is?
Hold on, rewind really fast. Which one was the PA, the 200 or the 50?
200.
It's 4:1 to the PA, so the PA is 200.
So the 4 is the PA.
The 4 is
not
the
one.
PA. So when it says 4:1 to the PA,
Okay.
that means that he wants he wants the most to the PA.
Oh,
So what he's saying is that the tumor is closer to the PA. So he wants more dose from the PA.
okay. Okay, you can fast forward now, sorry.
It's okay. So absorbed dose. Can somebody tell me their idea of what absorbed dose is?
Amount of dose measured in a tissue equivalent.
Okay. Tissue equivalent material or the patient, something like that. Okay. So it would be measured in centigrade? Yes. Would be measured in air. Okay. Close. It's also given dose, but yeah. So for absorbed dose, it has to be in the tissue. It can't be measured in air because air is not tissue. Okay, so let's go on to some clinical stuff now. Did anybody, I keep asking you and I'm sorry, who hasn't got the book yet? Okay, I did look and it is in the bookstore if you care to go buy it in the bookstore. Anyway, so I did show you some PowerPoints, which I said to you last week. What part of the tongue is the anterior tongue?
Upper two.
The part that, yeah.
That looked loose. Yeah, the anterior, not the upper, the anterior 2/3. So it's the part that actually you can wiggle. So how is the lip usually treated? What type of treatment do we treat the lip with? What did we say about the lip? It's treated like what type of tissue? Like skin. Like skin. So what type of treatment would we use to treat the lip?
Electrons.
Electrons, yeah. Or superficial or orthovoltage if you have it, but electrons, that's correct. Why don't we treat the lymphatics when we're treating glottic tumors? Say again?
It doesn't have the fact.
It doesn't have lymphatic drainage. Somebody was reading the book. Or somebody was remembering. It does not have lymphatic drainage. So for a purely glottic tumor, we do not have to treat lymphatics. What do we find in the glottis? Say again? What?
Vocal cords.
The vocal cords. Which ones? Because there's true and there's false. True vocal cords. So we treat the larynx, which is the home of the true vocal cords. What kind of field size do we use? Anybody?
4x4,
I was gonna say,
I'm gonna say
Yeah.
6x6.
4x4, 5x5.
I was gonna say,
Usually it's a 5x5 because it depends on the stature of the patient. But it's usually a 5x5 we use, but a 4x4 is fine. Treatment for carcinoma of the nasopharynx. What is the primary treatment for carcinoma of the nasopharynx? Again, you mentioned this just last time.
let's see, is that what you're asking, tissue type?
No, I'm asking what let me just tell you, primary treatment for nasopharynx. What do we use, guys?
Photons?
No, I'm not talking photons.
6MB IMR?
Radiation therapy, that's all I wanted. Duh,
Oh.
why are we here?
Yeah.
So, no, 99 times out of 100, radiation therapy is the primary treatment for nasopharynx. So, Molly did the little slip of the tongue there. So we'll ask, what kind of tissue is nasopharynx, usually? What type of pathology is nasopharynx? In a matter of fact, what type of pathology is most of head and neck tumors? Or are most of head and neck tumors? Squamous cell carcinoma. Is that what you were thinking of, Molly? Okay. Okay, so I think we went over, yes, last Monday. Total doses, for example, nasopharynx. Can anybody give me an idea of the total dose for nasopharynx?
6,500 centigrams.
Okay, anybody get any other ones? It could be anything from 6,500 to 7,000.
Sounds about the same.
6,500 to what?
6,500 to 7,000 centigrade. So maxillary antrum or sinus. You'll hear it called either or. Maxillary antrum or maxillary sinus. Where is it located? Where is the maxillary sinus located? There's two of them. Where are they?
Skull,
Whereabouts? Skull's a big place.
in your face,
in the maxilla.
Up here.
It's right here. On the side. Yeah, the one you get, yeah. The one if you have sinusitis, it's usually there. Or sometimes up here. So, anyway. So if we have what they call an extensive carcinoma of the maxillary sinuses, what areas might it involve, apart from the sinus itself?
I.
A little more specific. Where does the eye sit?
Orbital, something.
Orbit. That's basically what you're looking at, because it can invade the orbit without invading the eye. So orbit, yeah. Where else? You're sitting here. Where is it likely to grow to or spread to? Orbit is one way. Where does it go the rest of the time?
Throughout the rest of the nasopharynx.
The nasopharynx is way back here. So we're not worried about that yet. Where does this usually spread to? Goes into the orbit. What would it do this way? Go into the nose. What about inferior?
I wanna say mouth, so.
Well, kind of. The hard palate.
Oh, okay.
And if it gets really bad, it can actually go into the brain. Okay. So why is immobilization of head and neck patients very important? Why do we need to immobilize head and neck patients?
The treatment,
Anybody we're treating from there up?
the treatment fields can be so small, and you have a lot of like organs, I guess, like important organs. That
Critical organs perhaps?
there we go.
Yeah, okay. So the fields are relatively small, and you have a lot of critical structures. That's exactly what it is. What the, yeah. So if we're treating the maxillary antrum or the maxillary sinus, and you're trying to avoid treating the eye, how would the patient be placed on a head base? So I'll give you the options without including the eye. The head is in a neutral position on a large, comfortable support is under the head. The chin is extended and the chin is tilted back, so it would be like that. The neck is flexed and the chin is tucked down to the chest, so be there. And the head position is not important. Those are the 4 options you have. Which one would you think is best to treat the maxillary antrum, maxillary sinus, without including the eye?
3 or 4 options.
4.
4,
I would say probably the first one. I
neutral
mean,
position,
yeah,
okay?
that or
One was.
There was 3, there was 4 options. One is in neutral position and a large comfortable support is under the head. Next one is the chin is extended and the chin is tilted back. The patient's lying like that. The next one, the head is flexed and the chin is tucked down to the
Oh, it's
chest,
not the
so
first one.
that way.
That
And the head position is not important.
That was my second guess.
Number two.
The head is extended and the chin is pressed up. You're right, it's that one.
Why?
Because it gets, sorry.
Everything else out of the
It
way.
gets everything else out of the way and you're able to sort of get in this way without shooting the eye. If you were this way, then you'd have great difficulty missing the eye.
I feel like it's still have a hard time missing the eye when you're in that.
It's as good as it gets, basically. It's a rotten treatment to have to do because you have such critical structures you have to avoid. And sometimes you just cannot miss the eye. You have to treat the eye.
we have a new start next week that's whole brain, eyes included. First time I've seen that. Actually,
So the eye is included?
eye orbits included at a 4-grade dose. I think it's 4 fractions.
On 4?
4 fractions, yes.
No, but on 4?
On 4, yes.
Wow,
That's weird.
okay, so
It's very weird. My therapist.
I'm wondering whether it's not really as it seems. This would be what I would have
The plan's not
thought.
made yet, but
No,
that is.
this is what I would think, maybe, and I could be totally wrong, because it's unusual to treat a whole brain and take the eye and put the eye in place. So everybody heard of the German helmet technique? Do you remember that?
Yes.
Yeah?
My therapist asked me about that the other day and I was like, I know that.
Good for you.
That's what she said.
So you tell me, what is a German helmet technique?
It's the supraorbital, whatever, to the EAM, to the vascular.
No, that's a normal one.
Was that? Yeah.
So the German helmet is actually,
It's a helmet, that's what
you
we're
come
talking
down
about.
here, and go like this. So what you described was a normal base of brain treatment.
We still call it
eyebrow.
a helmet, right? That's what
Yeah.
we call it?
No, that's fine. So a German helmet is
Darn.
basically, let me show you, is basically, let's see, you have the head, the eye, the nose is here somewhere, okay. So,
Vernon.
I know, it's a weird one. Okay, so what you do is
Use Fred.
yeah, I'll use Fred in a minute. So the field is like that, okay? However, what you do is you take the field, oh, let me just change the. Oh, okay. So that is your German helmet.
Wait a minute, so what's treated?
Oh, sorry, I've done it the other way, sorry. Duh.
I'm just saying, don't the lines be blocking?
I understood what you meant.
No, but I was confused because that doesn't even seem like a whole brain at all. If you're only treating the,
Whole brain.
So this area is shielded.
oh, okay, now, so shielding the eye basically.
You're shielding the
So
eye.
it's coming,
But the treatment, the field is all of this. So where the normal whole brain is angled, the field is angled this way, right? Goes through the supraorbital ridge, the EAM, And depending on the physician, either the mastoid or C2. So you go down this way. Whereas the German helmet, the field is at 0 and you shield to make the, so here's Fred. So what you would do is the whole field would cover all of this and all of this. Then you would come down and you'd shield the eye, come over, shield the mouth, and hit C2. And all of the rest of it would be treated.
So for a normal whole brain, your field would not come down.
You would do the normal whole brain, you would treat from the supraorbital ridge to the EAM to C2.
Would the field size still be generally the same?
No. The field size for the whole brain, the angled whole brain, is usually something like a 20 by 12 or 13, depending on the size of the patient's head. The normal one for the German helmet is maybe a 20 square, because you're shielding all of this.
Is it more of a straight line for the normal, from the orbital ridge to the EAM?
Yeah,
the
it's
diagonal?
like this.
So you're just taking the
It's
field
angled.
and angling it, basically?
Yeah,
Okay.
yeah. And the same on the other side. But the German helmet is at 0. Let's see if I can find that.
I'm not sure I know what at 0 means, but.
Well, the collimator is
So
at
it's
0.
not angled at
No.
all? Okay.
The collimator is a 0. Let's see if I can find that.
Because they just have to be different, don't they?
Well, oh dear, why is it not? That's weird. It's on. Let's take that off and try again. Okay. Is it coming on? I've got it up here, so. Let's see if it'll come up. Okay, so. Why is it not working? Yeah. Let's try this. leave that in for a minute. Let me know if it actually comes up. I'm gonna have to call. Okay, so, we asked this before, but I'll ask again. Majority of cancers in the head and neck are squamous cell. Okay, so you have a very large patient. And the head has to be in a neutral position. So think about a football player, no neck, big guy. You have to get him onto the machine, and you have to put him on a head base. He has no neck. How do you get him in a neutral position? So do you want a low support under the head? You want a low support under the chest, a high support under the chest, or a high support under the head? So do you want to make his chest higher or his head higher? Or maybe not. Think about it.
I feel like you would want the head lower so it would be more.
But he can't put his head lower.
One of the options was a low head.
Neutral.
I thought there was an option around a low head.
It seems like to me, if it's a big dude, using the big rest is going to raise his neck abnormally higher than the rest of his body.
You want the head in a neutral position. At the moment, it's stuck and you're trying to put him lower. You've got his chest here and his head way back here and he's having difficulty. So what do you want to do? You want to raise his head up into a neutral position, right? So this is B. You try and put him on B. What happens? His chest is here and you're trying to get his neck here. Is it going to work? First of all, no, because he doesn't have a long enough neck. And second of all, if he can't get his neck back, it's not going to be in a neutral position. What's a neutral position?
Where your spine is straight.
Just lying straight and the head is comfortable like so, okay? If we were doing a larynx, for example, we would want the head back so we can treat here, right? At the moment though, this is making his head go back. It's really uncomfortable, he's not gonna make it. So we raise his head. This is the same slope. This is an F. You see the difference? So if it was a really big, heavy guy, and maybe he's not a really big guy, but he's having difficulties breathing. If you try and put his head back, he can't breathe. So you need his head up higher. So put him on an F and see if that works. Okay. So you want him in a neutral position. Still nothing. Okay.
Campus support, this is Randall.
Oh, hi Randall, it's Jane Wiggins King up in second floor A building. I'm in classroom 20. I'm in 209 and I can't make the projector work. Could someone come up and have a look at it, please?
Okay, I'll be over 1 second.
Thank you, bye. Okay, so meanwhile, so what else can we do about this? Where are we? Okay. So what kind of head and neck tumors would we treat? We've gone over larynx. We've gone over nasopharynx. What other head and neck? We'll ignore the brain for the moment because it's something that's not really, as far as radiation therapy is concerned, it's not really head and neck. So what other areas would we be able to treat? Carotid.
Very common.
Carotid? Did you say very common?
Salivary gland tumor, just.
It's not really that common, actually. Salivary gland tumors, most commonly parotid. The chances of you treating,
And it's the exception to head and neck cancers as well. So like, most of it being squamous cell carcinoma, is it
Parotid,
parotid
yes.
adenocarcinoma?
that's correct, yeah. So what other head and neck tumors would be likely to treat? So we've said nasopharynx, what other pharyngeal tumors? What other,
Oropharynx.
yeah,
Oropharynx.
and, what's the other? Oropharynx and? There's 3 pharynxes
Oropharynx, nasopharynx.
and laryngopharynx, so they're relatively rare, but we do treat them occasionally. What else? So what have we got? We had the tongue, base of tongue, thyroid. What's the treatment of choice for thyroid, however?
Chemo. No, I'm sorry, sir.
Iodine, surgery. Is it 120?
Surgical, what was that?
It's 131. But most of the time they try surgery first. Hey, come on in. Hi. I've got a PowerPoint up and the projector is on, but it doesn't seem to want to do anything. I checked the back, have all the plugs seem to be, oh, for heaven's sake, what did you do?
It was muted.
Oh, so if it's muted,
Yeah, this mutes.
It goes away?
This mutes the screen right here, this
Oh.
button, so you just have to unmute. It's okay, that's what I'm here for.
I knew that it's same with everything.
Nice.
You get the expert in, he presses a button and everything goes,
Happy to help.
thank you.
You want?
Okay, I feel like an idiot now. Okay, so, let's go back to my little thing. What was I doing? No, it wasn't that one. Oh, wait. It was this. Okay. Here, let me just, I'm gonna douse the lights completely so you can see it. So there is, so there's the gentleman helmet. This is what it's actually been called after. And here you have the whole brain, or the whole head, basically. And here's the eyes. So you're shielding the eyes, the mouth, and down here. And it is at 0. The collimator is at 0. And it's usually a 20 by 20 or thereabouts. So that's what they call the German helmet technique. So I'm wondering whether it might be this, because it is open field till you put the shielding on. But I could be wrong, and it could be something weird like.
Well, the plan should be done when I get back, so I'll get back to you next week about it.
That's okay. There's no. We're fine. So let's get back to. So we did the thyroid. The majority of the time, they'll do surgery on a thyroid, and they will do an I-131 treatment just in case the surgery has missed something. Would we treat it? Would we treat thyroid though? Could we treat thyroid?
I'm sure we could.
Yeah, the thyroid, we usually get thyroid patients if they're a bad surgical risk or if it's too advanced for surgery. Or somebody refuses to have surgery. So they may do an I-131, what they call ablation, which is what? An I-131 ablation.
Destroying tissue.
Yeah, basically you're destroying all of the thyroid. That's the theory behind the I-131 ablation. You're destroying the actual tumor. But if for some reason it fails, then we can go ahead and treat with radiation, external radiation, I should say. So do we do the I-131 in the radiation therapy department?
Isn't that pill that we take?
It's a drink. Do we treat it do we give them the I-131 in the radiation therapy department? Or do we send them elsewhere?
I'll say send them elsewhere.
So where would elsewhere be? Which other place in the hospital would they deal with radiation? Med. I'm glad nobody said X-ray. Okay. Nuke med, yeah, nuclear medicine is where you send people for scans or for especially I-131 treatment. Now you can use I-131 for a thyroid scan, you just have a very much smaller dose that you give. Okay, so what else? We've got thyroid, we've got nasal, oral, laryngeal, pharynx, we've got larynx, we've got parotid or salivary tumors, we've got maxillary sinuses or the other sinuses. What have we missed? What other things? Well, tongue, we mentioned last week, right? So what other things do we treat? Mentioned lip. What's floor of mouth? What encompasses the floor of mouth? Anybody? Mandible?
Yeah, that's what I was
It's-
gonna say. Everything underneath the tongue.
just below the tongue.
What's that area called?
Hmm?
Floor, is that just called floor mouth?
Floor mouth, yeah, it's floor mouth. And we usually, if we're treating floor mouth, we treat the tongue. Because that's the first place floor mouth will invade, is the tongue, the lower portion of the tongue. So we treat the tongue as well. Okay, what about the nose, or nasal tumors, or orbital tumors? You don't get them very often, but occasionally you get a nasal tumor. And in adults, you don't get an orbital tumor very often, except for melanoma. You get an orbital melanoma, which can be very nasty. I think I'm gonna give you a break here for the moment. And it's a head neck surgeon from Johns Hopkins. So it gives you some interesting photographs of head and neck cancers.
Ooh.
So this is normal oral cavity. So give or take the
Fillings.
fillings and stuff, this is a normal mouth.
It is.
There's no, well, as far as cancer goes, it's a normal oral cavity, right? There's nothing there as far as, this is totally normal. Oh. This is cancer of the tongue. Here is one, here is another, and there's little bits back here. There's some of this stuff which is called leukoplakia. You've heard of leukoplakia? What's leukoplakia?
White spots.
White stuff,
Like
White
thrush,
spots.
Kinda.
white spots. It's not really a thrush, no, because thrush, remember, is a fungus.
But it looks like it.
Yeah, so basically leukoplakia is a precancerous condition. And it's white areas, but this is tumor here, and definitely here. So, head and neck cancer, cancer of the nose, mouth, lips, gums, tongue, throat, voice box, and other sites. 50,000 people a year in the US. Curable 50% of the time. This is probably, it's an older slide, so it's probably a lot more since then. So causes, smoking, tobacco and smoking, alcohol, HPV-6, environmental and hereditary.
I feel like that one, number 5, is jumped up on the list.
It has.
I'm seeing it a
It
lot.
had, it's, although you would think it would be less now because of all of the kids that are actually being vaccinated. They're vaccinated now, I think, start at age 12. I think, for
think so.
HPV vaccinations. So you would think it would be less, however, HPV is still, for both head and necks, any head and neck, it can be there. So as it says, smoking, tobacco, smoking, and alcohol. How to treat head and neck cancer. Find it usually late, depending on what it is. So over 80% of tumors are late stage, with the exception, for some reason, of larynx tumors. They tend to be early. So surgery, you cut it out, radiation, you burn it, chemo, selective poisoning, or all of the above. So if the surgeons get to it first, then obviously they'll get it, they'll take it out. And then they may send it to us, plus chemo. And as I said last week, most patients' head and neck, apart from larynx tumors, most patients in head and neck are chemo radiation. And the chemo acts as a radiosensitizer. So not only are they getting a reaction from the chemo and reaction from the radiation, the chemo enhances the reaction of the radiation, so they're basically miserable for the 6 or 7 weeks that they're on treatment. So, key to curing cancer. Stop all smoking, causes more cancer deaths than any other factor. So, which cancers do you know, absolutely know, is a prerequisite for, is smoking a prerequisite for? Lung cancer. Head and neck. What else? Any head and neck cancer. Most head and neck cancers, basically. What else?
I feel like most of the body is can be linked to smoking.
Yeah. Esophageal, somewhat. Stomach, somewhat. Liver, somewhat, although alcohol is more, but yeah. Wait 30 years. Time required for relative risk of lung cancer to return to one after smoking cessation. So if you smoke and you're 25 and you stop right now, by the time you're 55, you'll be back to relatively normal risk. Ignore cancers due to low-level exposures, multifactorial genetic predispositions, and stochastic phenomena. Okay, tell me what these are. Low-level exposures. Low-level exposures of what? Low-level exposures of chemicals.
Smoke.
Secondhand smoke, maybe?
Any kind of
Does-
inhalants.
Yeah, okay. We're not just talking about smoking now, right? So low-level exposures could be chemicals. You work with chemicals, or your significant other works with chemicals, or your parents work with chemicals. Same as if you have secondhand smoke. If your parents smoke, but you don't. If your significant other smokes, but you don't, you're still getting secondhand smoke. Your kids, if you're a smoker or your significant other is a smoker, they are getting secondhand smoke. Multifactorial genetic predispositions. Okay, what does that mean? Multifactorial predispositions, genetic predispositions.
Having more than one genetic connection
To
to
what?
disease, cancer.
To cancers. Okay, so give me a couple of genetic predispositions. BRCA1, BRCA2, okay? So BRCA1, BRCA2, What has that predisposed you to?
Ovarian, breast cancer.
Ovarian,
And
breast
prostate.
cancer. Excuse me?
And prostate.
And prostate, yeah, don't forget about prostate. So what else is there? Ashkenazi Jewish, yeah. So that is, again, breast cancer, ovarian cancer, and prostate. What else is there? Is there anything else?
I'm sure there are.
Oh, yes, there's lots of them.
I can pull up my genetic report.
No, I don't think so. Thank you. No. Neurofibromatosis 1 and neurofibromatosis 2. They predispose you to other types of cancers. Okay, and stochastic phenomena. Think back to your radiobiology, if you can think back that far. That's this time last year. Think about it. Stochastic, what is stochastic?
Long term.
Okay. So you've been exposed to,
Is that random?
Radiation therapy treatments.
well, no, because you're out of the room when they're doing radiation therapy treatments.
I thought you meant people in general.
Oh yeah, people in general. But that would not be, yeah, I guess it could be.
What about, was living under power lines
No.
proven to be?
No, it's still up in the air and we don't know yet. What about if you live at a
High altitude.
high altitude and you get more cosmic rays?
Yes.
Are you more susceptible to cancers?
Yes.
No.
What about people who fly in the airplane, pilots and staff and stuff, because they're closer to the sun
Yeah,
and radiation?
it has not been proved. But they do get more cosmic radiation. Living in Denver, for example, or as I did living in Calgary, which is about the same level, we got exposed to a lot of, because we were high up, a lot more cosmic rays than here. And the rate of cancers is no more in Denver or Calgary than it is on sea level. Think about that. But it can cause damage to those who are skin cancers, for example. You get more skin cancers in high altitude. But for normal internal cancers, no. Okay, so cure cancers, prevention, definition of more subtle genetic or environmental risk factors. Targeted therapy, molecular or otherwise. Screening. Screening, conventional screening for non-genetic risk factors. Genetic screening for inherited cancer susceptibility. That's when you go into the geneticist and get your genetic profile. Or molecular screening for every disease. So conventional screening is what we're used to. Pap smear, colonoscopy, etc. Do we have screening for head and neck cancers?
You're trying to say,
It just will, I think, palpate, right? But then we talk about that one point.
The dentists. The dentist now, who's been to the dentist recently? Did the dentist feel your nodes?
No, but I know they're supposed to.
They usually don't feel my nodes. I don't think they felt. I
I've
know.
had it done once, maybe twice my entire life
Mm-hmm.
Yeah.
by a dentist. And I
Yeah,
remember thinking, that's really weird, what are they doing?
well, yeah, and they'll also do an internal check. They're supposed to
They
do
usually
an
do that.
external check. They're supposed to do an internal check as well. Sorry,
They usually do that for me. The internal.
they did do that?
Yeah, they usually do that.
Yeah. It's supposed to be done at your normal yearly exam or 6-monthly exam, whichever you happen to go to. They're supposed to do that then. Okay, so pre-malignant changes. Ignore the teeth and ignore this is your, so this is leukoplakia. This is pre-malignant condition. Leukoplakia, because leuko is white, leukoplakia here. That is a pre-malignant condition. So, advanced oral cavity squamous cell. So definition of advanced oral cavity carcinoma, historical data, surgical approaches, etc., etc., etc. So, advanced oral cavity cancer, so big tumor, T3 and T4, any nodes. T3 is greater than 4 centimeters. It's a big tumor. T4A, invasion of adjacent structures, cortical bone, deep tongue muscles, maxillary sinus, and skin. T4B, unresectable, invasion of masticular space, pterygoid plates, skull base, or carotid encasement. I'll send you this PowerPoint, you can look up all these beautiful words. So small tumor with neck metastasis, T1, T2, N2 to 3. So what does this mean? N2 to 3.
Notes.
Positive note.
Positive nodes. So it's less than 4 centimeters, T1, T2 is less than 4 centimeters, with 2 or more cervical metastases, 1 or more contralateral cervical metastases, or cervical metastasis greater than 3 centimeters. So what it's saying here, cervical metastasis, so that means that you've got nodes, cervical nodes, or cervical nodes, in 2 or more different areas. So you can have some here. If you have a tumor on this side, you can have some here and some here. 1 or more contralateral cervical metastasis. What does that mean?
Opposite sides.
Contralateral. Opposite. Okay. What does that mean? So you have a tumor here, where are your nodes? You have a tumor on the right side, you have contralateral nodes, which means you have nodes on the left side. Or cervical metastasis greater than 3 centimeters, which is pretty big. So, primary surgery and radiation indicated. So low control for primary radiotherapy for advanced oral cavity and poor survival, 25%, 30 to 40. So increased local control with surgery plus radiotherapy so that would be 60% local control. And improved survival, 55%. Or local control, significantly improved for T3, T4 oral cancer using surgery and post-op radiotherapy versus primary RT. So they want to go in, do the surgery first, then follow up with radiation therapy. So, this is just, I'll scoot through these so you can actually see them. So this is transoral. So you, in this case, you're gonna take away this lot, gonna peel it back, you're gonna take out the nodes and the tumor, and then sew it all back together again. So here is, it looks like they've taken some of the bone away. So they may have to take some of the mandible away. You've got a tumor here. So they've taken basically all of that out, some of the bone away. So lip split without mandibulectomy and lip split with mandibulectomy. So they're taking away some of the mandible. So transoral, cosmetic but may limit exposure. Lip splitting, modest cosmetic disadvantage with excellent posterior exposure for mandibulectomy. Anytime you have this mandibulectomy, cosmetic result is not what I would call modest disadvantage. Because you're taking away the jaw, or part of the jaw. So what does that leave you with? You've no jaw. Well, you hopefully still get the other side, but yeah. Well, I'm not talking about how you would eat, but how do you look?
I've seen somebody like
This is,
that.
this is a cosmetic, they're talking about cosmetic, modest cosmetic disadvantage. I wouldn't call what is left a cosmetic, modest cosmetic disadvantage. So the approach determined before incision and mandibulectomy or mandibulotomy, accurate assessment of bone erosion, involvement in neural structures. So here's the mandible. So they have to be careful because of all these wonderful nerves that float around the head and neck. Okay, reconstruction. Mandibular reconstruction. They use the fibula and scapula. Soft tissue. Radial forearm, rectus abdominis, and lateral thigh. Resection is rarely limited by size or extent of tumor. Okay, so contraindications. T4B, invasion of vestibular space of pterygoid plates. So this, where is this? Can you see? Give me an idea. Where? On the chin, yeah, you can see the lower lip there. So it's right here. So it's not on the, it's actually grown out.
Oh,
It's not just on the skin. It's actually grown through.
So the bottom picture is the same.
that looks like one whole tooth,
Yeah.
just laying sideways.
Pardon?
Fall out. It looks like one of his teeth just laying sideways, about to fall out.
How can you, I just can't understand.
So this is probably the same patient, but I don't really know. But it looks as if it might be because of all, you see, all of this is tumor. All of this is tumor. And yeah, this is a tooth that's fallen out. Because it's not been fallen out, it's actually been pushed out. Because this is all tumor. This is one tooth that's still there. These are a couple of teeth that are still there. But all of this is tumor. All of this is tumor. So it's gone right down. I'm gonna, yeah. So all of this is going right in, and it's going through, or is possibly going through this part. I hope you never see one of these in real life. It can be very nasty.
Imagine trying to eat with your mouth like that.
You don't,
Yeah, that's just crazy.
no.
Ugh.
And they stink.
Sure.
I'm sorry,
I
they,
can smell it by looking at
yeah,
it.
you can smell it from here, I know. But they stink. Patient perception of quality of life. So, what would you say the patient's perception of quality of life is for this thing?
I mean, I assume that they adapt to it as it grows and they don't notice it as quickly as you would imagine. And your adjustment period is
Okay.
an adjustment, but at
So-
some point you gotta go, man, why do my teeth keep falling out? This is really weird.
Well, it's underneath, this is the tongue, so it's underneath the tongue. So the possibilities is that he can maybe eat soft foods. But it would be extremely difficult, and I would say that this patient would say his quality of life is not good. I would use some stronger language, but I don't want to in here. So yeah, this is not good. This is not a, this would be a palliative patient, even if they did manage to do surgery on it. This patient is not gonna survive, unfortunately. Okay, so this is, a European trial. So this is primary surgical therapy followed by post-op chemo and radiation. In 2004, this is when the trial started. So previously untreated squamous cell carcinoma, all head and neck sites. So they have 167 patients, 5-year median follow-up. So 100 milligrams per meter square, cisplatin day 1, 22, and 43, and during post-op radiation or post-operative radiation alone. So 100 milligrams per meter square. Depends on how big the patient is, how much treatment, how much chemo they get, right? And day 1, 23, and 43. And here's one, T3 or T4, any N, except T3N0 of the larynx with negative resection margins. So what does negative resection margins mean?
The margins that were checked around the perimeter of the cancer came back negative cells, cancer cells.
Okay. So T1 or T2 and N0 or N1 with pathological extranodal spread, positive resection margins, perineural involvement or vascular tumor embolism. So extranodal spread, what does that mean? So we have N0 or N1. Pathological extranodal spread and positive resection margins. Nodal spread would give us N0 or N1, probably N1 if you have nodal spread. What's extranodal spread? So that would be what? Where might it have spread?
To the nearby tissue,
Yeah, nearby tissues, bone,
lymph vessels maybe?
Hmm?
Lymph vessels?
no, if it was lymph, then you'd have an N1. Anything outside of the lymph nodes. So anything that says lymph would be N1 or N2 or N3. Extranodal would mean that it's spread elsewhere, but no nodes. So it could have, if you had an oropharynx, it could have spread to the nasopharynx or the laryngopharynx.
So if you have a lymphatic vessel that has cancer itself, is that
It would
considered
go
an
to the
in-
nodes because the lymphatic tissue or the lymphatic liquid goes to the nodes, so it would get stuck in the nodes. Because the nodes are there to do what to the lymphatic liquid?
Filter it,
Pardon?
filter it.
Filter it. So anything that is abnormal would get stuck in the nodes.
So there's no such thing as lymphatic vessel cancer, like getting abnormal cells in the lymphatic vessel?
No. That's how it spreads, but it would go to the nodes. And here you have oral cavity or oropharyngeal tumors with involved nodes, lymph nodes at level 4 or 5, which is really far advanced. So overall survival rate was 53 versus 40. Local regional failure was 18 versus 31. And severe grade 3 or higher adverse effects were 41 versus 21. So what do we mean by adverse effects or severe grade 3 or higher? So adverse effects, so this is the effects of the treatment. So say we are treating, let's go with head and neck. Grade 1. So it goes from 1 to 4 usually. So we're saying grade 1 would be a little difficulty in swallowing. What would grade 3 be? Pardon?
Swallow, I don't know.
Can't swallow. Okay, yeah, can't swallow. And grade 4 would be you have to put an NG tube in or a nasogastric tube in or a gastric tube in to help them swallow. So there's clear advantage, so post-op chemoradiation for advanced head and neck cancer. So clear advantage in local regional control, survival advantage, and difference in enrollment criteria may suggest survival advantage for locally aggressive tumors without significant neuronal disease. So they're saying that
Steven?
I didn't even see him, I'm sorry.
Snuck out of here.
I thought somebody was coming in. I didn't even see him move. I should have looked and thought, oh yeah, he's there. Okay. So they're looking, so this is post-op chemoradiation. Sorry. Why is it better? No. Why is it different to do post-op treatment, radiation treatment, rather than pre-op radiation treatment?
I feel like, I don't know if this is right, I'm just guessing, but I feel like after surgery you could do less dose. Because if you got the whole thing there to treat, it takes a lot.
Yeah.
And if it's gone, and you're just treating to make sure it doesn't come back, then you don't do
Or most of it's gone,
Or most of
sometimes,
it's gone.
yeah, sometimes
It's a smaller area to treat.
Yeah, okay, yeah. However, just to play devil's advocate here, sometimes we do pre-op treatment so that we can what they call debulk.
Yeah, like shrink it a
So we
little bit.
reduce it so that the surgeons have a better chance of getting all of it. The reason why we do more post-op treatment is because radiated skin and tissue is very difficult. It takes a lot to heal it. And it sometimes doesn't close as well. So the surgeons go in and there's all this fibrotic tissue because we've knocked the hell out of it with radiation. And the tissue through where they're going is very fibrous, very damaged tissue, which makes sense because you're built with radiation. And the surgeons have difficulty closing the site, and also the patients take longer to heal after being irradiated. So that's why a lot of times we will do post-op treatment. However, if we have to debulk, then obviously we'll do pre-op. So this is, so we're doing radiation alone or molecular treatment. This is monoclonal antibodies. You've heard the term monoclonal antibody? I think I've mentioned it somewhat before. So we're doing this plus radiation, or we're doing radiation alone. And we've got 213 patients versus 211, and they're randomized. So the patient, basically what they'll do, the patient doesn't do it, but the physician does. There's a big tub, if you can imagine a big tub of numbers, and each patient has a number. And you go into one tub and you think, okay, patient number 305 gets radiation alone. And patient 306 gets antibodies or monoclonal antibodies plus radiation. So it's totally randomized. You just pick from one tub and they get radiation alone. From the other tub, they get the other treatment. So, median survival. So this is 28 months versus 54 months. 2-year survival, 55 as opposed to 62 months, or 62%, excuse me. 3-year survival, 44% versus 57%. Grade 3 to 4 mucositis, 52% and 55%. That's not too bad. And of course you have infusion reaction. We don't get infusions, but these people do because the monoclonal antibodies are given through an infusion. So they have a 3% reaction, grade 3 to 4. And then you have grade 3 to 4 skin reaction. The radiation alone is 18%. The monoclonal antibodies plus radiation is 34%. What does this tell you about the skin reaction? The infusion is looking like it's doing a, pardon? Yeah, radiation sensitizer. So it's acting as a radiation sensitizer for skin reaction. It's not doing it as much for mucositis, but it is for skin. So, multimodality therapy for all but very early stages, surgery and radiation with adjuvant chemo. Significant morbidity due to therapy is possible, cosmesis, decreased saliva, swallowing dysfunction, social dysfunction. Novel molecular directed therapies incorporated into next generation of trials. So they're looking for molecular, like the monoclonal antibody type people, are looking to do clinical trials with radiation, chemo, plus the molecular therapies. So let's go through this. So morbidity. So what's morbidity? Something that you'll come up against a lot. What's morbidity?
Like complications.
Yeah, pretty well. It's the side effects. So you have the morbidity scales. This is what you were seeing over here. This would be a morbidity scale, grade 3 to 4 mucositis. Usually it goes from 1 to 4. So what is mucositis? Anybody? Mucositis. Yeah, mucosal membrane. So if you have a sore mouth and the inside of your mouth is really inflamed, that's mucositis. So grade 1 mucositis would be, it's sore, but you can manage it. Grade 4 is you need some intervention, you need some meds for that stuff. So, okay, so cosmesis. If you have surgery, radiation with adjuvant chemo, you're going to get a sore mouth, you're going to get difficulty swallowing, you're going to have difficulty eating, which obviously works when you have difficulty swallowing. And then you have the surgical scars into the bargain. Cosmesis is not good. Whereas if you don't have surgery and you just have chemo radiation, you have all of the other things. You have the sore throat, you have the reddening of the skin, especially if you're having chemo as well. But all of that goes away eventually. And you have a reasonable cosmetic result. You don't have any weird scars, and your mandible hasn't been taken out, and all that lovely stuff. Decreased saliva. If you're treating the head and neck here, you're going to be treating the parotid, at least part of it, which means you're going to lose some saliva. Or the saliva that you have is what they call ropey, which means it's really thick. So what happens then? You have to keep drinking. You have to wander around with a water bottle, but everybody in Florida wanders around with a water bottle anyway, right? But you have to keep drinking lots. You have no saliva. What does saliva do? What's the functions of saliva?
It helps to break down food, but also moisten it so that it's easier to swallow.
Yeah, and,
Digestion, hygiene.
yeah.
Yeah.
It helps clean the mouth, basically. So if you have no or very little saliva, you don't get your mouth cleaned at all, then you'd have to mechanically clean it. Swallowing dysfunction. So even if you have had lots of treatment and you've managed to survive the treatment, you may still have problems swallowing, even although we've got rid of the cancer. The reaction to the treatment may give you your trachea and your esophagus, the upper part of the esophagus, may be not as flexible as it should be. So you may still have difficulty swallowing. And then you have social dysfunction. What might that be? What might social dysfunction be?
I'm a hermit.
Why?
Because
Dogs, the dog,
Pardon?
would be painful to speak.
Yeah, it could be painful to speak, even if though sometimes you may lose your voice, or your voice may get very gravelly, and you may have difficulty swallowing your saliva, so you may be miserable, a hermit. But that can cause social dysfunction as well, because anywhere else in the body you can cover things up, but up here, if your voice has been changed, or if they had to remove all of your teeth before they started treatment, and then they have to wait for a certain number of months before they can put dentures in, then you're going to be a little more leery about going into public spaces. So here's a 73-year-old edentulous farmer. What does that mean? Edentulous.
I guess it has something to do with his teeth,
Yeah,
the dent part.
yes.
Right, gingival lesion, so.
We're not going there yet. What's edentulous?
Maybe he's got dentures.
No, he has no teeth. So he may have dentures, but he has no teeth. He has no teeth. With a right gingival lesion, otherwise asymptomatic. He's a 120 pack a year smoker, currently smoking. Past medical history has diabetes, coronary artery disease, myocardial infarction types 2, carotid endotherectomy, peripheral vascular disease, and hypertension and renal insufficiency. Oh my goodness. Okay, so exams shows a right lower gingival mass, 2.5 centimeters, and it is a squamous cell carcinoma. Would he be a good or a poor surgical candidate?
Probably
Yeah.
not good.
He would be a very poor surgical candidate, right? Because not only does he have diabetes, but he's in 2 myocardial infarctions, he has peripheral vascular disease, hypertension and renal insufficiency, and coronary artery disease. So anyway, let's see. So, CT demonstrated right mandibular invasion. Right here. Right here. That's pretty good. Boom. So he not only has got a cancer, but it's actually spread to the mandible and into the bone. So PET-CT demonstrates no evidence of metastasis. An angiography, an MR angiography demonstrates severe peripheral vascular disease in bilateral lower extremities. What does that mean? Peripheral vascular disease in bilateral lower extremities. Take a guess, guys.
He's probably got,
Terrible circulation. Both legs.
In his legs. Yeah, basically. He has very poor circulation in his legs. Or lower legs, I should say. Okay, so he's a T4, wow, N0M0 squamous cell carcinoma of the right alveolus. So they're gonna do a right mandibulectomy via visor or lip split, right neck dissection, fibula-free flap, tracheostomy, post-op radiation and chemo. Tracheotomy, tracheotomy, post-op radiation and chemo. I'm surprised I actually did surgery on him, but anyway.
okay,
So we're not doing that, obviously.
What that?
We're not doing that.
Just scratch the whole thing.
clearly
We're
this
not
person
doing that.
had a whole speech he had planned with this.
So transoral mandibulectomy, post-op radiation to primary site and ipsilateral neck. So they're taking away the mandible, or part of the mandible, the right mandible. Transoral, so they're going in through the mouth and are taking away the mandible, right mandible. And then they're gonna do post-op to primary site and ipsilateral neck. And ipsilateral means what? Ipsilateral,
One side.
same side, not one side, same side. It is one-sided, but the ipsilateral means that it's the same side as the primary site. So since it's a right-sided, so it will be right neck nodes. So resection from paramedian to angle of mandible to encompass alveolar nerve. So they're gonna take away, oh, just did it for me, sorry. So that much. So they're taking away this and this, all of this. Oral alimentation at 4 days or 5 days post-op. External beam radiation to primary and ipsilateral neck onset 3 weeks post-surgery. Acceptable cosmetic appearance. Nothing at 30 months, but died shortly after from MI. So he lived 30 months after this. And then died from an MI. Okay, so 41-year-old traffic manager with a left lateral tongue cancer. 2 years of leukoplakia with documented high-grade dysplasia, prior incisions ×3. Recent 1.5 centimeter lesion excised, demonstrated squamous cell carcinoma with positive deep margin. No history of smoking or ethanol intake. So no smoking or drinking. So 2 years of leukoplakia with documented high-grade dysplasia. So what's dysplasia, ladies and gentlemen?
Abnormal cells.
Abnormal cells, right? So So recent 1.5 lesion excised, demonstrated squamous cell carcinoma, positive deep margin. Okay. Okay, so there you are. Exam is remarkable except for a small lesion on his left lateral ventral tongue. So this is it.
How they spotted that is beyond me. It's so normal colored.
Yeah. But it's
But
probably
we get
thickened.
such random bumps in our tongues.
It's probably
Mhm.
thickened. This is the kind of thing that the dentists are supposed to pick up, guys. So no uptake, so PET CT, no uptake in the tongue, moderate intensity uptake in a level 2 9mm lymph node and a 7mm left posterior IV lymph node. No evidence of distant metastasis and chromosomal breakage study negative. So he's as good as you can get. A T1N0M0 squamous cell carcinoma, left lateral tongue, and then you have a T1N2B M0 squamous cell left carcinoma tongue by PET. So clinically, this is what he's got, but you have the PET scan and you're seeing this. So probably we'll go with this. So left partial glossectomy, transoral, left neck dissection, level 1 to 5, sparing the IG, IJ, SCM, CN6. So these are the nerves. Level 5 include to ensure excision of posterior level 4 node found on the PET. So IG, IJ, SCM, and cranial nerve 6. I can't remember these ones. I should know this one. I can't remember. I'll look it up and send it to you. So 1.5 centimeter squamous cell carcinoma, a glossectomy specimen with negative margins. So 5 out of 35 nodes are positive squamous cell carcinoma in neck dissection. 2 out of 5 level 1 lymph nodes squamous cell. 3 out of 7 level 2 lymph nodes squamous cell. So the pathological stage is T1 N2B M0 and is a stage 4. So left partial glossectomy, left neck dissection, level 1s to 5. So basically he has no neck nodes left. So he's probably indented quite a bit. So post-op, external beam radiation therapy with competent cisplatin days 1, 22, and 43. Come. Okay. So. So who's got their book with them? Okay. So I'm going to go through some abbreviations with you. Oh, let me go and grab something. I'll be back in a minute. Look at the abbreviations in the front.
Are we in a different class from dosimetry after our break?
No, it's just dosimetry.
Oncology 3 now? I mean, not that it's not relative, I'm just, it's like.
I know.
Just one class or two? This semester? Yeah, that was just a semester.
Okay.
No,
So,
just dosimetry.
doing these. Just get those. Okay, so,
Is it a page number?
Just the.
it's the abbreviations in the front,
It has like a.
right at the beginning. Got it? Oh, that was not good. Okay, so, most of these you'll know, some of them you won't. And I went through some of them and made some notes. So, 131 CS is cesium-131. 2D, 3D, 4D. I-125, palladium-109. AB is an antibody. ABC, active breathing coordinator. Everybody know what that means? Oh, okay. It's a device that works for patients receiving radiation therapy for lung cancer or abdominal tumors. It's a way to help the patient breathe gently.
Oh, like those little things they pump over there?
Pardon?
We have a thing that goes across that we pump up with air.
Yeah, and it helps them to,
Yeah.
yeah. This one's a very high-tech one. American Brachytherapy Society is just seeks to promote clinical and lab research into frontiers of the knowledge of the specialty. AP, obviously, BED, biologically effective dose. And BEP is a combination chemo, bleomycin, etoposide, and cisplatin. So BID is, as everybody knows, twice daily. BOS is base of skull. BOT is base of tongue. BT is brachytherapy. BX is biopsy. Everybody know that one? Okay. CA is celiac artery. Everybody tell me where the celiac artery is.
Isn't CA also for cancer?
Yes. But in this case, this book is saying celiac artery, yeah. Where's the celiac artery? Anybody know?
I feel like it's associated with the digestive system.
Yeah, it's in the abdomen, the abdominal cavity. Okay. CBCT, the next few you'll know. CBCT, centigrade, CMs, COG is Children's Oncology Group. That's a group that does research into children's cancers. It used to be, and sometimes you can still see it in books, is POG, which is Pediatric Oncology Group, but now they've changed it for some peculiar reason to Children's Oncology Group. CRT is conformal radiation therapy. CSI is craniospinal irradiation. CTV is clinical target volume. CTV elective dose, CTV high dose. So these are the ones, some of the ones that the dosimetrists use. DD is depth dose. Dmax is maximum dose. DRR is digitally reconstructed radiograph. DVH is dose volume histogram. EBRT is external beam radiation therapy. EBV is Epstein-Barr, which sometimes is a precursor to some types of treatment or some types of disease. ECE is extracapsular extension. So what does that mean? Anything? Extracapsular extension?
Something emerging outside of a capsular area.
Capsular area, okay. What's a capsular area?
Outside lymph nodes, maybe?
Yeah, it could be, or if you have, say, a kidney, you have a capsule of the kidney, and then it goes outside the kidney. So anything that's outside of the area or the tumors, the area itself that's in. Okay, extra pleural pneumonectomy.
That sounds awful. They replace it with something else?
No, it's a surgical treatment for malignant pleural mesothelioma. The surgeon removes the diseased lung, part of the pericardium, part of the diaphragm, and part of the parietal pleura.
There's gotta be something put in there though to keep things organized. Otherwise you have
Well, what's the pleura?
intestines shooting up in places they shouldn't be, and
What?
if you don't have a diaphragm or a pleura or anything there separating top from bottom, once your digestive tract
Well,
starts shooting up.
Yeah,
it's
they're only removing part of the diaphragm, they're not removing all the diaphragm, they're just removing part of
I
it.
know, but that's what I'm saying, I wonder if they replace,
It could be,
they might have to
Yeah.
have a patch
Could
or
be.
something.
yeah. So that's what that is, okay. ENI is elective nodal radiation. EUS is endoscopic ultrasound. What would that be given? Endoscopic ultrasound. What's an endoscope? If you have, sorry, go ahead,
Scope that normally goes down your throat.
or elsewhere. You can do it, colonoscopy is done through endoscopy. So the scope is a long tube with usually a camera or a pair of scissors on the end that can snip off things. That's an endoscope. So endoscopic ultrasound is that you have an ultrasound that goes in through the scope. Where were we? Oh yeah, FDG, fluorodeoxyglucose. Where might we find that? We were talking about it this morning in passing.
And what, the FDG?
FDG, fluorodeoxyglucose. Pardon?
Used for PET scan.
Used for PET, yeah, used for PET. So FH is favorable histology. FRST is fractionated stereotactic radiotherapy. FRT is fractionated radiotherapy. FLAIR, fluid attenuated inversion recovery. I had to look this one up myself actually. Who did MRI when you were doing with Mr. Graham? Who did MRI? So what is a T2? T1, T2, do you remember?
I thought that was a change in contrast, like it could expose different depths of tissue.
Yeah,
I don't remember which one.
there's a type of tissue. So the FLAIR, the fluid attenuated inversion recovery, is an MRI sequence that produces strong T2 weighting, suppresses the CSF signal, and minimize contrast between gray matter and white matter. So there you go.
Which one was that?
Flair, F-L-A-I-R.
Let's see, yeah.
FT, of course, is feet, FX is fractions. GEC Estro is the European Society for Therapeutic Radiology
God, I hope that doesn't show up on there.
and Oncology. Why not?
That's a mouthful to remember.
Not really, it's the same as Astro or RTOG, it's exactly the same. It's just the European one instead of the GEJ is gastroesophageal junction. GK is gamma knife. GTR is gross total resection. GTV and all the little GTVs under it, a gross tumor volume, a brachytherapy, and one at diagnosis. GU is genitourinary, gray is GY, head and neck is H and N, HAM is Harrison Anderson Mick. And Harrison Anderson Mick are applicators used for the treatment of skin surface, mucosa, and tumor bed and organ surface. And these are used in intraoperative radiotherapy. HDR is high dose rate. HPV, we all know is human papillomavirus. HR is high risk clinical tumor volume, or target volume, excuse me. HRCTV is high risk clinical target volume for brachytherapy, and a lot more information on them are in the book. HVL is half value layer. ICRU is International Commission on Radiation Units and Measurements, and you'll see that occasionally. IDL is the Isdose line. IFRT is involved field radiation therapy. IgG, immunoglobulin G. Most common antibody is in the blood and other body fluids and protects against bacterial and viral infections. And it's actually a good one. IGRT, we know. IM is internal margin. IMRT. INRT is involved node radiation therapy. Intermediate risk clinical target volume. IRS is intragroup rhabdomyosarcoma study. ISRT involves site radiation therapy. ITV is internal target volume. Somebody was talking about that the other week. Intravenous is IV. KV is kilovolt. KEV is kiloelectron volt. LDR is low dose rate. LG is low grade. LN is lymph node. LNI is lymph node irradiation. LND is lymph node dissection. LUL is left upper lobe. LVSI is lymphovascular space invasion. And MALT, space invasion, the invasion of tumor cells in lymphatic or other blood vessels. So that's what we were talking about earlier, where it would go into the lymph node, into the lymph liquid, but it would get caught in the lymph nodes. MALT, M-A-L-T, what is it? Mucosa-associated lymphoid tissue. So it is diffuse system of small concentrations of lymphoid tissue found in various submucosal membrane sites of the body, such as GI, nasopharynx, breast, salivary glands, etc. MIP, maximum intensity projection, that you can see that in CT. MEV is electron volts, ml is milliliter, MLC is multi-leaf collimator, is millimeter, MPNST, malignant peripheral nerve sheath tumor. It's a rare type of tumor that occurs in the lining of the nerves that extend from the spinal cord of the body. These used to be called neurofibrosarcomas. Oh, I missed one. MIBG, iodine 131 meta idobenzoguanide. It's a radiopharmaceutical used for both imaging and treating certain types of neuroendocrine tumors. So there you go. MR, we know, MR per hour, millirem per hour. MV is megavoltage. Nodular lymphocyte predominant Hodgkin's lymphoma. NSCLC, non-small cell lung cancer. OAR is organs at risk. PA is posterior anterior. PDD is percentage depth dose. PJ is pancreatogynostomy. And no, it is not Whipple. What is Whipple? What's the name for Whipple? So the jejunostomy is original pancreatic duct drainage procedures. This surgery involves the resection of the tail of the pancreas and the spleen and creation of an end-to-end pancreatogynostomy procedure while preserving the duodenum and the bile duct. What's different in the Whipple?
It's a periodic duodenectomy.
Which involves what? You've obviously got it there.
The head of the pancreas is first part of the duodenum.
And? Saying about the bile duct?
The same.
Okay.
It's,
Okay,
but,
that's fine. Where were we? Oh, yeah. So primitive neuroectodermal tumors, which are mostly the children's tumors. Perineural invasion. Partial response. Prostate fractionated irradiation trial. So that's a trial going on, profit. PRV, planning organ at risk volume. PT is proton therapy. PTV times 3 is planning target volume. PV is a portal vein. Retroperitoneal lymph node dissection. And RPM, real-time position management. Who's working with Varian machines? Okay. This is the Varian RPM system is a patient-friendly video-based system that compensates for target motion, enabling improved imaging and treatment in areas such as lung, breast, etc. So this is a breath hold type treatment, which is from Varian. And I'm not sure whether you guys have it or not, but no, okay, that's fine. So let's see what else we have now. SAD is source to axis. SBRT is stereotactic body radiation therapy. Setup margin is SM. SMA is superior mesenteric artery. SOBP, spread out Bragg peak, which is from obviously protons. SRS, SSD. So Stampede is a system therapy in advancing metastatic prostate cancer evaluation of drug efficacy. So So you probably won't see it unless you're in a department that does a lot of clinical trials. TRT is thoracic radiotherapy. TSEBT is total skin electron beam therapy. TURBT, transurethral resection of bladder tumor. US is ultrasound. UH is unfavorable history. A VAC lock, which is vacuum locking, bet you didn't know that. VMAT, which is volumetric modulated arc therapy. WAI, which is whole abdominal radiation. WBRT, which is whole brain irradiation. WHO is World Health Organization. WLI is whole lung irradiation, which we very rarely use. And WPRT, which is whole pelvic radiation therapy, which again we very rarely use. So this is just basically the abbreviations which you'll find in the book.
Question.
Most of them you know.
On the board exams, how many abbreviation questions do you think there will be, or any?
There may be a few, but they will be,
More commonly used ones?
they will be the Joint Commission. The Joint Commission approved abbreviations. There's a list of them and I'll try and get them for you.
Because there's like so many abbreviations for literally everything.
Yeah, there's a, for most places, especially the hospitals, they are supposed, and I say supposed to use the Joint Commission approved. But then you've got the physicians who
That do their own thing.
don't care. I gave you a list of abbreviations in that white book.
Yeah.
A lot of them are not approved by Joint Commission, but you'll still see them used. If not by the therapists, by maybe the nurses and definitely the physicians. But I will get you a list of the approved abbreviations from Joint Commission.